Rsacp to bring you this webinar with the most eminent speakers and the choicest of topics that will take us through management of areas. Before we begin the webinar, I'd like to welcome and thank the eminent faculty for joining us, the webinar chairpersons, and of course, our webinar patrons, that is Dr. Naveen Malhotra, who doesn't really know, sir, but for all of those who've joined in, this is Professor Naveen Malhotra, the director at the ARS Pain Center and the fellowship director of the Pain Management Fellowship, which is recognized by the RSACP. He's also the president of the RSACP and the president-elect of ISA National. Welcome, sir. Thank you so much for joining us.
Thank you, Dr. Gauri, and heartiest congratulations to Rsacp Maharashtra branch for organizing this webinar. Today, I am joining in dual capacity as a president and also as a faculty, and I'll now hand it over formally to Vishal and Swati Singla. Vishal Singla, because he's driving. So Swati Chavda as a joint secretary will take care of the role of the secretary. So over to you, Swati, and the rest of the team. Thank you very much.
Thank you, sir. A very good evening to everyone. The patron of the society, RSCP, the president, immediate past president, and all the GC members, and foremost the faculty and the audience of the current webinar. So RSCP has been very active in organizing activities related to academics and research. And as part of that, we have very regular webinars which have been covering all the topics since many years now. And no topic can be more pertinent for an anesthesiologist than the airway. Airway, everything starts with airway, ABC, and it's very important part of the CPR also, CAB. So we cannot be more pertinent while discussing airway, and the discussions can go on and on. So I thank Maharashtra state chapter for coming forward and bringing this topic to the foreground as it always has been, and getting a very interesting lineup of topics for today for the benefit of the audience. And these will also be available on YouTube to be watched later if anyone is busy. So you can circulate in your groups also. Now I hand over. I seek permission from the President, Dr. Naveen Malhotra, sir, to give permission to start the today's webinar. And he's, of course, there as faculty as well. Sir, please.
I think Dr. Tej Kaur has joined, so you could take permission from him.
Yes, sir, of course. Dr. Tejke Kaul, sir, with your permission, sir, can you please give your guiding remarks and give us the permission to start the webinar?
Permission granted for any academic event started and led by Rsacp. Today's topic is very important, essential for every person. The retromandibular intubation and other is the very liked topic by Dr. Naveen Malhotra. He rather discovered the technique, I think more than 20 years back. And I was talking to Dr. Vishal. I said, when Dr. Naveen was of your age, this retromandibular intubation was the pet topic of Dr. Naveen. I wish that all members of Rsacp hear him very keenly and put any number of questions they need to get things clarified. Best wishes for today's webinar, and thanks to all the organizers and others who are attending it. Thank you very much.
Thank you so much, sir, for your guiding words and always blessing everyone who is there as a part of Rsacp. Now I hand over the proceedings to the Rsacp webinar moderator for today, Dr. Gauri Ganga Khedkar. Please proceed with the proceedings for the today.
Thank you so much, Dr. Swati. Before we begin what promises to be a really exciting webinar, I would like to take this opportunity to introduce and welcome our chairpersons who've taken time out of their busy schedules to be with us today and to give us insights over what promises to be some thought-provoking conversations and talks. First and foremost, we have Dr. Indrani Hemant Kumar. It gives me such great pleasure to introduce Madam. Madam is Professor Emeritus in the Department of Pediatric Anesthesia at St. G.S. Medical College and KEM Hospital, and she is my guide. Welcome, Indrani, ma'am. Ma'am, could you unmute yourself, please?
Thank you, Gauri. Uh, as Sir said, airway is such an important topic, and everything starts and ends, and the nightmares also starts and ends, for all anesthesiologists with the airway. And it is one of the most important tasks of clinical anesthesia. And in fact, because difficult airway is associated with a very high rate and severity of complications and even death. So when it comes to Leafort fractures, it can be a nightmare to an anesthesiologist. And that's when this retromolar and submental intubations can really save our lives. And I'm so happy and honored to have Dr. Naveen Malhotra presenting this topic. As Dr. Tejkal said, he himself has invented, this method of intubation, and to hear it from the horse's mouth, what else we need? And thank you very much for that. And I would like to ask Dr. Naveen Malhotra to kindly proceed with his topic.
Thank you, madam, for those kind words. And I still vividly remember 30 years ago when I was a senior resident. I did this technique for the first time. And the day when I was supposed to do it, the submentotracheal intubation, before that, how much planning went. It was a 16 years old boy with panfacial trauma, and he was to be operated by facial and plastic surgeons. And I must congratulate and thank in absentia my seniors in PGI Chandigarh. I still remember Dr. Neerja Bharadwaj was the consultant on the table, and the plastic surgery head, the MCH senior resident of plastic surgery, who said, "Don't worry, apply the knife, we are there." So, and then the journey continued with the Professor Chavda supporting me when I came back to PGI Rohtak. Because at that time, I will share funny incidents with you, how it happens. But I bring myself greetings from PGI Chandigarh, from when I did this technique for the first time there, PGI Rohtak, where I did it for almost 2 decades consecutively, and then subsequently switched from submentotracheal to retromolar intubation. And my current place of work, Rsacp Management Center. And to be honest, I am also a bit excited that after a long time, I am talking about a topic which is not pertaining to chronic pain. So I was just going through the slides, so I also felt good. So we all understand that this is our conventional route of intubation, the orotracheal intubation. But when we have to do a facial reconstructive surgery or a patient who has undergone panfacial trauma, this is a very, very important step. The maxillomandibular fixation intraoperatively, which is required by the surgeons to restore the dental occlusion so that the implants can be applied and the facial symmetry is maintained. So once this intraoperative maxillomandibular fixation has to be done, then orotracheal intubation is rendered impractical. So this is our Second conventional route, if you are not able to do orotracheal intubation, you do a nasotracheal intubation. So we do a nasotracheal intubation, and we do with it. But when there is a fracture of nasoorbital ethmoid complex, there is active CSF rhinorrhea, active epistaxis. The surgery is done in the nose or in the nasoorbital ethmoid complex, then nasotracheal intubation is also not possible. So this was the older route, tracheostomy, preoperative tracheostomy, so that the surgery can be done and airway can be maintained post-operatively. But we all understand that tracheostomy has its own complications, immediate, late, and delayed. So to avoid tracheostomy, the retromolar intubation has been designed. It is a simple alternative to tracheostomy, which is an invasive technique, and subendotracheal intubation, which is minimally invasive technique for securing the airway perioperatively. And I'm happy to share with you that we published around 10 articles in national and international journals, which are from index pertaining to retromolar and subendotracheal intubation. This was published in IJA as an original article, and Dr. P.F. Couture was the editor. In orotracheal intubation is initially done with a flexometallic tracheal tube, which is then placed in the retromolar region. The retromolar region is the space behind the last erupted tooth, the molars or the premolars. If you put a finger in your mouth, you will see that there is a space behind the last erupted tooth. So you do a orotracheal intubation with a flexometallic tube, manually reposition it into the retromolar region, and this is stabilized in position by fixation to first or second molar tooth. So this you can see, this is the picture demonstration. We published it in Anesthesia 2006 also as a simple alternative to submental intubation. I'll show you a video. So this is orotracheal intubation has been done with a flexometallic tube. And then you manually reposition it with your index finger behind the last erupted tooth. So this takes a curved position going from the angle of the mouth behind the last erupted tooth. And then you fix it with the dental wire in figure of 8 fashion. So this is fixed in the figure of 8 fashion. We can use the dental braces or the space between the two tooth to fix it. Avoid doing an overzealous fixation. It will take a curved route, and if initially it was 21 centimeter angle, by this curved route it will be now 2 centimeter roughly more, 23 centimeter at angle of the mouth. Definitely while doing this procedure, because there is some period of apnea, so we put it initially on 100% oxygen. And now you can see that the tube is lying by the side and they are operating on the same side also. So they are operating on the nasoorbital ethmoid complex also, maxilla also, mandible also. So we understand that orotracheal and nasotracheal intubation is not possible in such patients. With this type of surgery going on, putting a plate and screws. So At the end of the surgery, you remove the maxillomandibular fixation and unwind the dental wire and manually reposition it again back from retromolar intubation to orotracheal intubation. And then extubate as per the standard practice. So key to success to retromolar intubation is adequate retromolar space, which can be judged by putting your index finger in patient's retromolar region, a gloved index finger, and then asking the patient to close the mouth. If there is no compression on finger, that means there is an adequate space. You can increase the success by choosing one size smaller. So instead of putting a 7.5 centimeter endotracheal tube in a female, you put a 7, or instead of putting an 8.5 in a male, you put an 8 centimeter with the corresponding lesser outer diameter, the success is increased. Earlier, if the space was not adequate, osteotomy was done to make the space. But, and the tooth were extracted, the last molar, but extracting the last molar tooth, destruction of the bone, which may be useful for fixation of fracture fixation devices. So all those things, if they have to be done, they render retromolar intubation impractical. So we never did in our practice osteotomy on table and extraction of the last molar or premolar tooth, erupted one. That was not done. We used a one size smaller tube. So if the retromolar intubation can be done, we have been doing it very, very frequently, then it avoids the need of any surgical technique, the tracheostomy, or the minimal invasive technique, the subendotracheal intubation. There are certain disadvantages also, but they're very, very minor. The tracheal tube can interfere with the main surgical field. Too jealous fixation can damage or deform the tube, and it is not positioned properly. It can interfere with positional and application of dental fixation devices. But over the last 17, 18 years, we never had any such problem because we used to fix the tube away from the surgical field, as you have seen. And even if it is positioned on the same side of the surgical field, the bilateral mandibles have to be operated. Still, we could get the surgery done comfortably. However, in certain patients, especially those who are obese and chubby, there is inadequate retromolar space and dental occlusion is not possible. So in those patients where we cannot do intraoperatively maxillomandibular fixation, then we have to go for some endotracheal intubation. This is the picture of some endotracheal intubation, where the tube, orotracheal tube, is going to come out through the submental canal in the submental space. So this was the first article, well, first case when we did it way back in 2000, 2001, and published in Indian Journal of Anesthesia in 2002, and subsequently in other journals, the different varieties we did. So the most common technique which is done is the lateral approach. There's a midline approach also and a submandibular approach also. And in this, we do a orotracheal intubation, again with the flexometallic tube with standard general anesthesia technique, and then convert it into subendotracheal intubation. So this is the video. This is the one of the earlier time when I was young, and you need some equipments for cleaning and ripping, like if a blade with handle 15 size blade, a curved artery forceps, equipment for cleaning and ripping. So we have done intubation with the flexometallic tube, whose tracheal tube connector is removable. Before starting the procedure, we switch on to 100% oxygen, monitor the vitals very, very carefully. Mika, 1.5 to 2 centimeter incision parallel and medial to the inferior border of mandible. 1.5 to 2 centimeter incision parallel and medial to the inferior border of mandible around just at the lateral edge of the mentum, starting from the lateral edge of mentum, and do a curved artery forceps, applying counter from this opposite index finger, remaining as close as possible to the inner aspect of the mandible, because it's a no man's land with no vessel, no nerve, and only you are there with the mandible. You go across the skin, subcutaneous tissue, and myloid muscle, and open in the floor of mouth. Here you can see our teacher, Dr. Savda, sir. So you open up in the floor of mouth and first take out the tracheal tube pilot balloon. And then again introduce the curved artery forceps through the submental tunnel. It is again reintroduced. And you open up in the floor of mouth. Take out the tube, but and ensuring that you are applying a counter through the other hand, so that there is no accidental extubation. Once it is out, you fix the and join the circuit, check for the bilateral entry and capnography, and then fix it just like we fix any other intercostal chest tube drainage. Intraoperatively, the intermaxillary fixation can be done to restore the dental occlusion. So this has been done, and the surgery can be done comfortably. So this is a patient whose tube is lying on the one side. At the end of the procedure, you open up the intermaxillary fixation, and you can extubate it through the submental tunnel itself. However, if you want, we can convert it back to the orotracheal intubation and extubate through the orotracheal, and then apply two interrupted sutures with 2-0 silk. This is the midline approach where you remain straightway in the midline, but the proposed advantages are less bleeding, less incidence of sublingual duct involvement, easy tracheal tube passage. But we and other literature have shown that lateral technique is the most commonly used because it is technically very easy. We avoid damage to the sublingual duct and the submandibular ducts by opening under vision in the floor of mouth. We have also used two tubes technique. It is indicated when tracheal tube connector was not removable. Earlier, there were certain tubes whose tracheal tube connector could not be removed. So we used two tubes. One was converted from orotracheal to submentotracheal, and the other one was introduced from outside to inside. I will just show you the video of that. So, if you so this is the dissection done, and a curved artery forceps has been introduced from within, from outside to inside. Then we take another curved artery forceps and bring it from inside to outside. Now this will hold the tip of the tube, and now this tube will be drawn in from outside to inside. So now there are two tubes, one which is orotracheal and one other which is from submentotracheal, drawn inside. So under laryngoscopy, we will remove the orotracheal tube. We're putting on 100% oxygen first, definitely. And then do a careful suctioning. This tube has been removed, and the tube drawn from outside to inside will be positioned with the help of magnal forceps into the orotracheal submentotracheal route. So that the advantages of two tube techniques is that there is less risk of compromising the patient's airway. Disadvantage is tracheal tube cuff damage while grasping and drawing in the tracheal tube. However, nowadays we have tubes whose tracheal tube character is removable. Submandibular intubation is in the far lateral end of the angle of the mandible, which is below 1 inch below and half inch anterior to the angle of mandible, and it opens in the mouth medial to the second molar tooth. Proposed advantages of the posterior approach is avoids trauma to the submaxillary duct and sublingual duct. We have done other things also like retrograde submentotracheal intubation. So when mouth opening was limited, our soft J-tip ureteric guide wire was advanced retrograde through the plicothyroid membrane. A submental tunnel was made under local anesthesia, and the guide wire was brought out from the submental tunnel. So from plicothyroid membrane to the oral cavity, and then to the submental tunnel. And the tracheal tube exchanger was threaded over the guide wire, and then finally the flexometallic tracheal tube was advanced over the tracheal tube exchanger into the trachea. Earlier we had these. Now we have got PVC tubes, but earlier there was silicone tubes. The flexometallic tubes are made of silicone. And while doing one procedure, the inflation tubing and the pilot balloon got disconnected. So we came up with this sleeve device, which was published as Malhotra and Malhotra in Anesthesia Analgesia in 2002. It is what we did was we took a 10 millimeter internal diameter PVC tracheal tube, 10 centimeter long, and it was split along its length. So this was the sleeve made. We made a 10 centimeter tube, 10 centimeter long, and slit along its length. And we enclosed the inflation tubing and pilot balloon in this tube. And the pull was applied over the sleeve and not over the inflation tubing and pilot balloon. So these are the things which we had to do at that time, because at that time, 20 years ago, 23 years ago, there was no PVC tubes. We have used, at times the tube got disconnected also, damaged also. So we have replaced the submentotracheal tube by use of tracheal tube exchanger, and the angle could be easily negotiated and without any difficulty. Yes, definitely good lubrication was done. So we had put this thing, put a tracheal tube exchanger, remove the damaged tube. You can ventilate also briefly to maintain oxygenation, and then you're removing the tube which you want to replace. And then place a fresh tracheal tube over the tracheal tube exchanger through the submental tunnel. We reported this in anesthesia in 2005 also. And if the tube has to be kept in situ for longer period of times, maybe patient goes to the HDU, the tube can be kept from 48 to 72 hours. So suctioning is easy, angle can be easily manipulated, and you can take care of the hygiene and the toileting of the lungs. So this was a young patient, I still remember, young boy from Punjab. This was my first case. This is the silicone flexometallic tube, and antibiotic cover is given as per the institutional protocol. Usually for trauma, broad spectrum antibiotics are given. And from our side, the surgeons also comfortable. The maxillomandibular fixation is done the next day. So day one, the maxillomandibular fixation is kept open postoperatively, so that if there is some vomiting, some bleeding, the patient can spit it out, and we are comfortable that our airway is open. And oral hygiene is maintained with chlorhexidine mouthwashes 4 to 6 times per day. And the stitches are removed on the sixth post-operative day. The two stitches you put usually for the segmental subcutaneous stitching. And the scar is almost invisible after 2 months. And it is lying below, so it is not visible until you extend your neck, and it is aesthetically pleasing also. We have kept it up to in situ for more than up to 3 days, and mechanical ventilation, trickle suctioning is easy through the tubes. And definitely nowadays we've got low pressure, high volume cuffs. The advantages of submentotracheal intubation are that it provides a secure airway, unobstructed intraoral surgical field, allows intraoperatively intermaxillary fixations, and avoids complication of tracheostomy. And these are the different indications which we have done for the craniofacial maxillary trauma, for facial reconstructive surgery, for mandibular setback, maxillary advancement, and all types of fracture, LIFO 2, 3, and even for the tumors of the base of skull. This was published for the tumors of the base of the skull, the clival chordomas. So this was published in Journal of Neurosurgical Anesthesia in 2004. So here you can see that the intraoperatively LIFO 2 osteotomy was to be done. So there was an incision to be made, and so these are all the retractors which are applied intraoperatively. And so nasal intubation was not possible. Oral was coming in the field. And this is, so we put a submentotracheal tube, so intraoperative X-ray, where this, the submentotracheal tube, the wiring is visible. And we have done it for numerous things, lots of patients of facial reconstructive surgery and tumors of maxilla. The contraindications are long-term airway support. After 72 hours, usually the patient, we do not keep it, otherwise a permanent track will be formed. There are certain disadvantages because it's an invasive technique. There are incidents of superficial wound infection. If you're not careful, then hemorrhage and trauma to ducts can occur, and orocutaneous fistula can be formed. But these are all avoidable disadvantages. So this was our experience from 2001 to 2004. We did 54 submentotracheal intubations, out of which 49 were pan-facial trauma, 2 were facial reconstructive surgery, the maxillary advancement and mandibular setback, 2 were neurosurgical procedures, transmaxillary excision of clival chordoma, and 1 was failed nasotracheal intubation. And majority of the patients were male because of the Rsacp accident, and submental incision was done most of the time on the right side, just for our own comfort. And submental fixation of the tube was done 2 centimeters more than oral. It took around 8 to 10 minutes to take the procedure, and blood loss was absolutely minimal. Definitely in one case, it was 20 ml, and as an anesthesiologist, a young anesthesiologist making incision, 20 ml was a bit scary. But then the surgeons taught us, no worry, take artery forceps and do a cautery. That's it, and it was managed. And average duration of surgery was around 5 hours. Majority were extubated on table, 52, 2 were extubated in recovery room. Route of extubation was through the submental tunnel, 50 patients, and converted to oral, 4 patients. None of the patients required prolonged ventilatory support. So this was the intraoperative disconnections of the inflation tubing, resulting in cuff deflation. So 1, extension of skin incision when we were budding surgeons, making incision to 4 centimeter 1, and bleeding 1 patient, which I discussed just now. Definitely, we had 2 subcutaneous infections. The image of subcutaneous collection was done, and antibiotics were given, and they settled within 1 week. There were no delayed, no failure complications. Then came retromolar intubation, and from 2004 onwards, we have done it in 115 patients so far. And out of them, we were successfully able to do retromolar intubation in 107 patients. And in 8, we had to do submentotracheal intubation because the space was not adequate. Again, these all patients were also young, and majority were males because the roadside accident somehow is more in younger and male group. And fixation of tube was more than 2 centimeters more than the oral in both retromolar and subventricular intubation. Definitely, retromolar took comparatively very less time, around 2 minutes, and both were extubation was retromolar converted to oral, and subventricular intubation through the subventral tunnel. No adverse events, no need for tracheostomy, and two incidences of subcutaneous infection in STI. But dear friends, whenever I talk about retromolar intubation, students get confused with retromolar scope-guided intubation. Bonfils retromolar scope-guided intubation is an absolutely different thing, and that also utilizes the retromolar space. But this is a Bonfils retromolar scope, which has got a curved tip. It's a light source, and the tube is reloaded over it. And when you unscrew this, the tube can be taken out with. So you have this is an equipment with a camera, with a light source, tube is reloaded over it. You see it, use the retromolar space, and then go into the trachea. Unlock the screw, and then this tube goes into the trachea. So just I've shown you because retromolar intubation is a different thing, and retromolar scope guided intubation is a different thing. So I conclude that in selected group of patients, retromolar intubation is a simple alternative to subventricular intubation for securing the airway perioperatively. When retromolar intubation cannot be done, then subventricular intubation is a useful and relatively harmless alternative to tracheostomy for securing the airway perioperatively. Thank you very much for your patience, and thank you for giving me this opportunity to share my experience of retromolar intubation and subventricular intubation. Thank you very much.
Thank you for that engaging lecture, sir. I think anesthesiologists definitely need expertise and skill to practice retromolar and submental intubation. I didn't see many questions. I think one question is there with Dr. Gauri. She has taken it from the audience. I think there is a problem with a lot of people want to join, but they are unable to join because the maximum limit has been reached. So
Ask them to join on YouTube.
there is a problem. So that itself says who Dr. Naveen Malhotra is. And the other speakers, Shilpa and Shraddha, both of them, all three of them. So one question is, why should we not extubate from retromolar position itself?
Ma'am, you can do it, but once you are unwinding it, it will take just one moment. Putting your index finger into the retromolar space and again converting it back into the
Oral.
putting the tube into the retromolar space and bringing it back is just a 10-second procedure. And then you can proceed normally as you want to. So we never had any problem
So the question is, why can't we just do it, extubate on as a retromolar position?
At times, madam, what will happen is when you're pulling it out, you will damage that cuff. Because you will be taking out through a sharp tooth. That will immediately damage the tube. And at times, if the space is too tight, so because once you are putting it, you are put with the pressure. And if you're able to pull it out, absolutely you can pull it out, but just to avoid damage to the cuff, because I know we're not going to use this tube again in any other patient, but still to avoid a damage to the tracheal tube cuff. That's it.
Okay. Gauri, do you see any other question?
Yes, ma'am. We have one more. We have Dr. Muthukumar asking that currently, so the newer flexometallic tubes that are available, the connectors are again those that cannot be detached. Is there a possible solution we can offer?
Yeah. nowadays we have seen all the tubes. They're correct. You just put your the upper end of the tube into the lukewarm water,
Right.
and then with the artery forceps, just swap it around. The glue will give away, and the connector can be removed.
Oh,
Oh, that's
really? Oh,
that's
just
Yes,
warm water.
you put it in the lukewarm water,
excellent.
and then take a artery forceps and swap it around the connector and the tube. It out.
Okay.
Between the connector and the tube, is it, sir?
Yes, yes, between the tube and the connector.
Lovely. Okay, okay, lovely. That's nice. So there's another question where they want to know, could we compare the efficacy of retrograde intubation and submental intubation or retromolar intubation? Is there a comparison that can be made?
See, we have published a comparison of, see, retrograde is totally different thing. The comparison can be done, has been done between the retromolar and submentrotracheal. But
Right.
comparison is a clinical one where we have published that by doing retromolar intubation, you need not put a knife, whether it is for tracheostomy or it is for a submentrotracheal intubation. But definitely, we were not successful in 8 patients over, I can say, 15 years. And this is all published data which I have presented today. And but we never had to put a knife for tracheostomy perioperative for securing the airway perioperative.
Right, sir. So maybe retrograde is something that we can save for those patients where the mouth opening is so little that retromolar is not really an option, where we're not able to.
Yeah,
Maybe possibly that is where they could use it. Dr. Paliwal also pointing out that they've done a lot of retrograde intubations and they've used epidural catheters instead of the ureteric catheters that sir you mentioned to carry those about. So have you considered using epidural catheters for submental
madam,
intubation?
I like to reinforce again here. Retrograde intubation and retromolar intubation are totally different things.
No, sir. Apologies, sir. So the sub for the retrograde submental intubation that the technique that you
Yes,
showed
yes,
in
you
the
can
urethra. So
see.
that
What we have realized is that while you are negotiating the tube, we were not able to put it over the JTIP guide wire also. So if you remember, I carefully showed that initially when we put a JTIP guide wire, when we are putting it over the negotiating the angle, we found it difficult. So what we did was we first put a airway exchange catheter, and over that we put uh, the tube through the submental tunnel. And we never you can epidural catheter has been used for retrograde intubation through the nasal route. Absolutely no issues with that. If you want to use that, you can use that also. It's up to us whether you use epidural catheter or a JTIP ureteric guide wire. Either
So
way.
we have one more question on the chat. It says that the Shikani stillet. This is with regards to the Bonfils. Shikani stillet is a similar device to Bonfils. So what would the difference be in their utility?
I'm again telling you, retromolar scope guided intubation. For that, you need an equipment, right? So whether
Right.
there are so many gadgets available, but they are an absolutely different technique where we use the retromolar space in patients who have got a limited mouth opening, like TM giant ankylosis, and we put the tube from through this scope into the this place, from going from the
Right.
retromolar space into the trachea.
Right.
But here I'm telling you, you are not dependent upon any gadget.
Equipment.
It is
Any equipment.
anesthesiology forte. Every anesthesiologist can do both the techniques with their own hands without requiring any costly equipment. So definitely there are equipments available, but where there are no equipments available, you use your index finger, use the space of the patient, use a smaller size tube. Use a smaller size tube. I have used 7 mm in pressures were high. I could do an easy ventilation with those chubby, bulky jaws like mine. So, but we can put it, the tube. So just decrease the outer diameter of the tube. and your success rate will be increased. Definitely, we got all those equipments available. You can use that equipment, absolutely no doubt about that.
So what would the minimal mouth opening required be for conducting a successful retromolar intubation?
See, at the end of the day, first thing in both the techniques is to able to do an orotracheal intubation.
Right.
If you're not
Perfect.
able to do an
Perfect.
orotracheal intubation,
Absolutely. Mm.
then like in one or two cases we did a cricothyroidotomy. For that, catheter was out, did a dissection. But still, I will say that is a one-off situation, elective procedures. If you are not able to do an orotracheal intubation, you need not use these two techniques. Go for FOB or other techniques which you want to.
Have you
Fantastic.
had accidental extubation?
No, never mind. Never have an accidental extubation because we always had one end of the tube in hand. Accidental extubation is it can occur in submentotracheal intubation when you are drawing the tube from intraoral cavity across the submental tunnel outside. So you are pulling the tube outside with the forceps and with one jerk it can come out. But what we did was the other hand was holding the tube intraorally
Hmm.
so that you take it out in a guided manner.
And do you pack the throat afterwards?
That is done for surgical thing only. So
No,
that,
no.
that
This is post-operatively, I'm saying, because they
meaning
have the dental wiring and all.
post-operatively, no packing is done. All packs are removed. Intraorally, we could definitely put a pack at the end of the surgery. Earlier, we used
Remove
to
the
do
pack and
maxillomandibular fixation with wires. Then came the tensile bands, elastic. Remove those bands, take out the pack, oral cavity suction done thoroughly, and then you extubate. Surgeons are also very happy in keeping the mouth open for 24 hours post-operatively. They can also check whether there is any bleeding, eh, the surgical swelling which may interfere, that is also taken care. Patient is also comfortable because at times there is nose is also packed. Majority of time there is nose is also packed for the surgery. So they are
hmm.
not able to, they are also able to breathe normally. Next day morning, 11, 12 after the round, they again put the maxillomandibular fixation for 4 to 5 days. That's it.
And thank you so much, sir, for a very exhaustive and a rather eye-opening conversation about retromolar and submental intubation techniques. Thank you so much for this talk.
Today was, let's not forget the techniques which we anesthesiologists can do on our own. And
That's true, sir.
I must thank in absentia my wife also because she does a lots of hydrointubation for opening up the fallopian tubes. A simple procedure which opens up the fallopian tubes with the use of just like we do HSG. So I thought I was just discussing about this webinar. So she said, "Why not you present your old work?" I know this journey started in 1990, and we are sitting in 2025. So 26 years down the line, and for last almost 15 years, I'm only asking my juniors to do it. So, okay, you do it, you do like that, and you do like that. And I'm more into chronic pain. But thank you to Shilpa and Dr. Indrani that they gave me an opportunity to relive my nostalgia of report. Well, we were the first one. I'm not saying I because it's a teamwork. We were the first one to report submentotracheal intubation and retromolar intubation in a patient with panfacial trauma from India in Indian journals, and we have around 10 publications. So credit goes to all. Dr. S.K. Malhotra, Dr. Madam Indu, Dr. Neeta Bhardwaj, Madam Chari, and Dr. Balveer Chavda, Dr. Charla Udda, and all my teachers with whom I shared this journey. Yes, I forgot to share this important thing. So once we were doing it frequently in PGI Rohtak, one day surgeon said, "I won't operate." So, why you won't operate? I will do I will do incision. Making incision is a surgeon's job, not an anesthesiologist job. So patient was intubated. I was scrubbed up. So Dr. Chavda came in. Right in the file, airway management is the forte of anesthesiologist. Surgeon is refusing to operate. Patient to be extubated. No, 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 sir. Wait, sir. Wait, sir. Let Dr. Naveen do the intubation. I'll operate. So at that time, he took the stance. So I always say in all my presentations, please do not take help of any surgeon. It is just a 1.5 to 2 centimeter incision, parallel and medial to the inferior border of mandible, just lateral edge of mentum. Go as close as possible to the inner aspect of mandible. Go skin, subcutaneous tissue, myeloid muscle, no vessel, no nerve, open in the floor of mouth under vision, no damage to the duct. Take out the tube, pilot balloon, take out the tube, fix it. That's it.
So you're making it sound so easy, and I know it's really not.
We have
No,
done it at Nair Hospital many times, but it was always the surgeon who did it for us.
No, no, I understand because we feel that why to apply a knife, but I guess I remember when I did for the first time, and I'm again placing on record my appreciation for Dr. Nirza Bhagwan. She let me do it, and I did it nicely. So the journey started from there. So you have to take some risks.
Very
So
true.
thank you very much. Thank you very much.
Thank you. Thank you so much, sir, for your time and for the lovely talk. Before we move on to the next talk, I want to introduce the rest of our chairpersons. We have Dr. Jason Doctor, who is a professor with us at Tata Memorial Center. Dr. Gauri Arora, the director at Aurora Hospital, Nagpur, and Dr. Umesh Ramtani, who is the associate professor at GMCH Nagpur. Welcome to the webinar today. We We'll now move on to our next talk, which is by Dr. Shilpa Tivaskar, which is supraglottic airway devices. And she's going to help us match the devices to their indications. So all of us have heard lots of talks about supraglottic airway devices, and there's such a gamut of devices available. Today, Madam is going to give us some insights on which surgery and what device we can use. Thank you so much, ma'am. I hand over to you now.
Yeah, thank you, Dr. Gauri. I thank Dr. Naveen Malhotra, sir, Dr. Vishal Singla, sir, and Dr. Indrayani, madam, to give us this opportunity. I also thank, am I heard properly, Dr. Gauri?
Yes, ma'am, absolutely.
Yeah. Yeah. And I also thank the chairpersons, Dr. Gauri Arora, madam, Dr. Jason Doctor, and Dr. Umesh Ramtani, sir. So today my talk is supraglottic airway device, which to match where. I'll be talking mostly for the private practitioners because we do not have all the complete set of gadgets, whatever new gadgets are introduced in the market. So let's see whether we are able to still manage the patient nicely. My agenda today will be use of supraglottic airway devices, which procedures we use, the common ones that we use, the intubating ones, the newer ones, and the references for which fits where. Now, the supraglottic airway devices, the so-called small procedures for surgeon, where do we anesthesiologists use it? So instead of holding a mask for a long time, suppose there is a DJ stenting and it's a difficult one. I'm doing with TIVA and now I have to add inhalational agent. So holding a mask for a long time or to prevent a tongue fall, there is obese class 1 or obese class 2 patient for DNC with some biopsy or polypectomy and it's going to stretch for say half an hour. So I don't want to do it on TIVA nor hold a mask, so to prevent the tongue fall. In a longer duration TIVA procedure, when we want to add an inhalational agent or a TIVA with muscle relaxant. So the so-called small duration procedures, of course, for us anesthesiologists, it's all anesthesias are major. Then for same, I have listed gynecological procedures for tympanoplasties, for MRM, chemoport insertion. So we anesthesiologists who in private practice frequently use laryngeal mass airways for all anorectal surgeries, for diagnostic laparoscopics, for DJ stentings, where we want to add something to TIVA, right, for close reductions, K-wire incisions. Sometimes if our upper limb block has not acted fully, for skin graftings, the list is very extensive. That day we had in our OT, my colleague had a unanticipated difficult intubation for a laparoscopic cholecystectomy patient. So either we put a Procel. We in fact couldn't see anything with video laryngoscope also. The epiglottis was overhanging, and we tried to include the epiglottis in the video laryngoscope blade. Dr. Jason can help me how I would have otherwise done it. But I couldn't still see it. And then we both of us decided that she puts an LMA till we take time to think. So either we continue the case on Procel, we put an Procel LMA. So we continue the case, or we take the patient out and rethink what to be done. Then in asthmatic patient, in COPD patients, we use the laryngeal mass airway. And we feel that any high-risk cardiac patient is there, insertion will cause less hemodynamic instability. Of course, for a obese patient, while I am ventilating the patient, if it's a heavy job, with two-hand ventilation is also not possible, I would like to use a laryngeal mass airway. And of course, CI/CO situation cannot intubate, cannot oxygenate, a very dreadful situation for anesthesiologists, as Sir said. We have singers who come for, say, lap hysterectomy. I had a female patient who was very apprehensive about intubation, and I assured her that I'll put a laryngeal mass airway, and of course, which will have not zero chances, but lesser than the endotracheal tube. Here, I want to tell something which is very, very, very commonly used, the oropharyngeal pressure. Now, this is the vocal cords, the laryngeal mass is sitting on it. And at airway pressure of 30 centimeters, what is happening? That all the laryngeal mass airway is sitting very tightly on the vocal cords, and whatever gases I am giving are going to the patient. But if my airway pressure increases to 35, what happens? Then this seal may get loose and some air may leak from the sides of the laryngeal mass airway. So, in airway pressure at which the laryngeal mass airway produces leak, it does not transmit all the pressure, does not transmit all the air volume to the patient, is the oropharyngeal leak pressure. If the oropharyngeal leak pressure is high, that means I can use it in patient where I have to ventilate with a higher inspiratory pressure. The prototype is Supreme LMA. Everyone knows that. It is a rigid, it is a preformed LMA, polyvinyl chloride, and it has many advantages such as integrated bite block, fixation tap, and it is the common LMA which is used. It can be also used as a rescue LMA. Then rescue procedures in an unconscious patient, or when you are doing a CPR and you are doing chest compression, and we don't have a expertise who is there at the head end, and the CPR is taking more than 20 minutes, you want to secure the airway, then someone can just put a Supreme LNA. When not to use. So initial years, when you are enthusiastic, we use it everywhere, but we should know when not to use. Of course, in patients with airway pathologies, in patients who are not fasted, risk of aspiration is there. Obese patients, pregnant patients, patients with gastric reflux history, then patients who have poor pulmonary compliance, because as we said, as the BMI increases, what happens? The pulmonary compliance will decrease and more inspiratory pressure will be required to ventilate the patient, and the oropharyngeal pressure may give leak, and hence laryngeal mask airway should be used carefully. And if there is a known difficult airway case, then of course you should try some other means of securing airway and not use laryngeal mask airway as a first device unless you are planning intubation through that. The iGel, again, what is the advantage of iGel over the Supreme? The iGel, it has a preformed cuff. It is made up of medical grade thermoplastic elastomer and a inflatable cuff. So it will fit the contour of the oropharynx. So that is the advantage. Plus, if you can see, it has a buccal cavity stabilizer and epiglottic rest is there. And hence, it is very easy to navigate through the epiglottis and it stabilizes in the oral cavity. The next, which is commonly used in private practice, is the Procel LMA. In Procel LMA, you can see that there is a reinforced airway tube. plus the drain tube is separate, and we can have the rear part of the posterior cuff which pushes the mass anteriorly. So there is a seal by the posterior part of the cuff to the esophageal sphincter. Now comes the main part, which should be used when, which is better. So when the Procel LMA came, they compared it with the iGel, and they found that comparison of Procel and iGel during gynecological laparoscopic procedures where Trendelenburg position could be used, they found that iGel also gives equal ventilating conditions as Procel. Again, one more article. Now they have compared Procel, Supreme, and iGel, where initially when you put iGel, the oropharyngeal leak pressure is only 20. But when you give after 30 minutes, when you give Trendelenburg position, and after 60 minutes, the oropharyngeal leak pressure is higher. That means the patient can tolerate with that LMA, the patient can tolerate higher inspiratory pressures and still get ventilated, still have good EtCO2. Sorry. So this is one of the study. Then one more study which came in 2016 where they did on 150 patients, Supreme, iGel and Procel. They compared many things. The first attempt of insertion, then whether the gastric contents were coming out through the tube, whether there was ease of gastric tube insertion, the cuff inflation, the ease of insertion. So other things were not statistically significant, but they found that oropharyngeal leak pressure was good with iGel, and hence they said that iGel could be used for laparoscopic surgeries, for surgeries in Trendelenburg position. Also, they found that blood staining complications occur in each LMA, but they found that blood staining was less with iGel and sore throat was statistically less with iGel. Now, till now, you might feel that, okay, iGel has an upper hand. Then we have some another study where they compared Procel with Supreme. And they said that Procel has a higher oropharyngeal leak pressure and it can be used for laparoscopic cholecystectomy. Then this is one more study in 2017. Again, a complicated table, but here if you look, first attempt with iGel out of 30 patients only in 22, whereas Supreme 29 out of 30 had good first attempt insertion. Again, if you see how much time to insertion, only 16 seconds for Supreme, for iGel 24. Again, if you see ease of insertion, only in 17 patients for iGel and Supreme 28. If you see the complex and the mean oropharyngeal seal pressure or the leak pressure was near the same in both the LMEs. If you see again blood staining, it's opposite here. In iGel, it is more. So what does all these references tell us? That some references prefer iGel, some references prefer Supreme LMA, some prefer Procel. But more or less, the airway leak pressure, the oropharyngeal leak pressure is nearly same in all the three types of LME. This is one more study by Dr. Raj and Dr. Anjali Bure madam, where they again compared the iGel with Supreme. And here they found that the insertion time was less with iGel. The blood on device was less with iGel. The sore throat was less with iGel. This is one more study comparing Supreme and Procel. They are saying that there is no difference at all and Supreme may be easier to insert. A comparison? No. Till now, what we compared which is easier to put, which has a good oropharyngeal leak pressure so that I can ventilate at higher pressures. Now, this study is which was published in 2020. What they did, they compared the gastric contents, the gastric insufflation because of the LM. What happens when we use in laparoscopic surgeries in Trendelenburg position? There is abdominal splinting effect of pneumoperitoneum, which reduces the thoracic compliance. So what happens? The airway pressure increases. And if there is a leak, the esophageal seal could be disturbed and air can go into the gastric cavity, which can cause for aspiration, regurgitation, aspiration, and postoperative nausea, vomiting. So what they found that antral cross-sectional areas, they compared between the supreme and igel and endotracheal tube also, and they found that there was no difference. That means this element, supreme and igel, you can use in laparoscopic procedures in Trendelenburg position as same as endotracheal tube without the fear of aspiration or any without the fear of any thoracic compliance, reducing the tidal volume. Now we have a new LMA, that is LMA protector. What is the advantage? It is again elliptical in cross section like our Supreme. It has two separate drain channels. But at the end, the male and the female suction tubes. The female drainage port and the male suction tube. Why? Because this suction port will again go at the back of the LMA and it will suck from the oropharyngeal space, and another one from the distal gastric port. Also, the cuff pilot of this is color coded. So here you can see green color is for the good pressure to 60 centimeters of water, red is high, and yellow will be little low pressure. So the designs in LMA have come so that it becomes more and more safe for the patient, and oropharyngeal secretions, which normally lie above the larynx, above the LMA, above the larynx, can be sucked. Now comparing, so as the new LMA comes, we have our good research people who compare it with the existing one. So LMA protector was compared with LMA proceed. The oropharyngeal pressures of LMA protector and proceed were compared. This is an IJ article. But same year, if you see another IJ article, it says that comparison of oropharyngeal leak pressure of LMA protractor and LMA proceed, then protractor had a higher oropharyngeal leak pressure. That means it tolerated more high airway pressures. Then now obese patients. In obese class 1 and 2, whether we should use these LMAs for procedures. So comparison of IGEL for general anesthesia in obese and non-obese patients. They found that oropharyngeal pressure was, of course, leak pressure was slightly lower in obese. At 25 centimeters of water of airway pressure, the leak started. But in non-obese, it was 27. So the difference was not statistically significant. So you can use iGel for these patients also. So we always, whenever we put an LMA, first thing what we do is when the patient is paralyzed, we adjust the flow to 3 liters per minute. Then we close the APL valve and we check for the oropharyngeal leak pressure. We do not allow the airway pressure to go above 40 centimeters of water. The British Journal of Anesthesia has an article where the Clocil, now here we saw that the protractor can be used in an obese patient, the iGel can be used. Now let's see whether Procil can be used. So the Procil laryngeal mass airway was effectively used for ventilation in a obese patient, in a myasthenic patient where muscle relaxant was not given and it was a morbidly obese patient and it did not cause any regurgitation and no hemodynamic compromise. Again, we have the LMA gastro airway where it has a strap, an integrated bite block and an adjustable strap. Now, this was supposed to be used for ogiriscopies, the endoscopies where the anesthesiologist is also comfortable. I don't know how people are using it outside, but at our center or in center near ISA Borivali, at least the surgeons, the endoscopic surgeons aren't comfortable with this LMA. They say that it might damage their scope, but otherwise it's a very useful LMA. Now, for infants, which LMA could be better, the Supreme or the Procil? The Procil LMA is superior to Supreme LMA for infants because it has a high oropharyngeal leak pressure and hence to have a proper seal, Procil can be used. And of course, now we have the third generation LMAs. So it has to still come. I have to still see. I have to see the SLEEPA 3G LMA being used in my practice, but to understand it, it has a self-inflating cuff which will adjust during inspiration, it will increase, during expiration, it will decrease, the cuff size will decrease. Then it has a space where the secretions can get accumulated and we can suck the secretions. So this is SLEEPA 3G, the third generation LMA. Again, it seals the esophagus. It has four unique protection mechanism against reflux. The gastric drainage channel, which is there, gastric tube, which is there, then collection in the chamber, which is there, and the reflex channel back to the cuff. So you have continuous suction of the cuff. Then we have comparison of third generation streamline. Again, now once this has come in the market, we have comparison of SLEEPA 3G with Supreme. So always whenever a new product is introduced, we tend to feel that the previous product had some fallacies. No, it is not so. The mean oropharyngeal leak pressure in Supreme LMA was significantly higher than SLEEPA 3G. So this was a very important study which they did. Otherwise, the oropharyngeal leak pressures during pneumoperitoneum, it were not statistically significant, but it was significant that the leak pressure was high in Supreme. So Supreme can still withstand the test of time. Then we have Air Q3G. So everything which has come third generation LMA. So here, if you can see, I could not get a better picture, but the cuff has a guide or a ramp for the endotracheal tube. Then it has an epiglottis elevator. And then it has a safety hole. So oxygenation can still reach while you are at it, while you are inserting it. And it has a built-in heel also for improved seal. So all these mechanisms are there to guide the endotracheal tube through it. Then we already have Blockbuster. We are using Blockbuster. We have Blockbuster in our OT. So this Blockbuster has got a mass airway, a gastric channel, and basically a four-way connector. If you can see here, a four-way connector, inflation pilot balloon, check valve, PT tube guide device, which is there here, and a dorsal. PT tube guide device and a dorsal. So you can guide the endotracheal tube through this LME, and Blockbuster LME. Blockbuster LMA comes with its endotracheal tube and a pusher. And recently, what they told me, Torrent people, that you can use one size smaller, like if in the Blockbuster 3, if I'm using a 6.5, a Blockbuster endotracheal tube, I can use a 6 number Cortex endotracheal tube after applying jelly with the pusher. So this can be used for intubating the patient. If you are not able to ventilate, you can put a Blockbuster and take time to think. If you want to intubate, you can intubate through it, or you can continue the case on Blockbuster or make the patient awake. Again, Blockbuster guided awake fiber optic bronchoscopic intubation was done in an ankylosing spondylosis patient. It's a very good article where the Blockbuster was put and through it in an ankylosing spondylosis where the neck was really higher. In spite of pillows, the patient could not raise the neck and bronchoscopic intubation was possible. Again, the second article you can see, these are 2024 articles, where LMA Blockbuster was compared with LMA Proceed in patients undergoing operative procedures, and we found that LMA Blockbuster was superior to Proceed in terms of insertion and oropharyngeal pressure. So you can maintain the patient on Blockbuster. Ambu Aura Gain. Ambu Aura Gain is a very good LMA. My experience with this, it is a stiff one, but once you put an Ambu LMA, in a 3-number Ambu LMA, you can easily blindly put an 6-number endotracheal cortex tube. Of course, when there is a difficult intubation, blind intubation is not recommended. So from this Ambu Ora again it is second generation, it has a gastric access intubation. There's a center air channel through which you can put a fiber optic scope and guided over it, you can put an routine endotracheal tube and you can intubate through Ambu Ora Again, IJA 2019, we have a study where Ambu Oragen was considered. Intubating conditions were considered with Ambu Oragen, and they found that there was 100% insertion. So you can insert Ambu Oragen easily, and then it can facilitate intubation. So it can be used as an intubating element. In between, we had Ambu Ora I, which was introduced. But of late, as I spoke to Ambu people, this has been withdrawn in the market, Indian market. Only few samples, if at all, are remaining because it was not of much use. Because direct intubation through fiberscope, through Ambu Ora gain was possible, and hence Ambu Ora I is not so much useful. Then LMA Fast Track, we have used this LMA Fast Track. Again, it comes with its own reinforced tube. The advantage is it has a handle stabilizer to it, and it is very easy. The curve is very easy to negotiate through the posterior pharyngeal wall, through the oropharynx, through the pharynx. And once you put it, you can just push the endotracheal tube. There was a comparison of 3 supraglottic airway devices for blind tracheal intubation, a 2024 article, where it shows that LMA Fast Track, AirQ, and Aura I were used, and LMA Fast Track and AirQ are more successful for endotracheal intubation. So I would suggest that every private practitioner should have at least one LMA Fast Track or one intubating LMA in emergency. Then this article, as I said, old is gold. So we can always compare Supreme to other newer LMAs which have come, comparing the AirQ versus LMA in patients with laparoscopic. Why we are stressing laparoscopic gynecological surgeries? Because their maximum head low is there. And now I have not included these surgeries where you have cancer surgeries for prostate or robotic surgeries where endotracheal tube is advised. So laparoscopic gynecological surgeries, if you compare them, LMA Supreme, the AirQ group exhibited a significantly lower oropharyngeal pressure compared to LMA Supreme. So LMA Supreme was good. Now the talk cannot end without Buska, which is the talk of the town. It has a cup where all the secretions will be accumulated, and you can see that this is something where there'll be, if you apply suction here, then and this part is open to air. So continuously the secretions can be sucked in. So about the Buska, it self-inflates during inspiration, self-recoils during expiration. It has high seal pressure. It has a unique ventral sump, which is called, and continuous sump suction can be done to clear the oropharynx and any gastric secretions are there. It has an insertion tab. This is the insertion tab. So if you want a more angle, you can just pull the insertion tab. And it protects against dental trauma. You have a bite block and protects bronchoscope's damage. Last few slides, again, Ambu Aura gain. It was used for, okay, now they have compared influence of head neck position for eye gel, Ambu Aura gain, and Buska mask in a anesthetized and paralyzed patient. So whether any, now initially they compared Ambu Aura gain, Buska, everything was good. Now again with eye gel, what they found out that Ambu Aura gain is the most suitable device for supraglottic airway management because of its anatomical adaptation. But in spite of differences in the oral pharyngeal leak pressure, the IGL it was 28, the Ambu Aura gain it was very high, 34.9, and Buska 10. So Ambu Aura gain, sorry, 30. So Ambu Aura gain remains the most suitable airway device. Again, C-track LMA had come in between, I'm sorry, where to the LMA, we have a fiber optic channel and a monitor where you can see while you are putting the LMA, and of course through this endotracheal tube will be pushed. Lately, last couple of months or maybe a year, I have developed the habit if I am putting LMA for a small to moderate or intermediate duration surgery. These are not my pictures, but I have a different picture saved with me. Then I put an umbu fiber scope and see whether my LMA is sitting properly. So this you can do for your self-assessment. Whether you, and of course, if the tidal volume is decreasing, the aspiratory tidal volume is decreasing, whether your LMA is sitting properly on the larynx. The talk doesn't end with video laryngeal mass airway, which has newly come, where you have one port which is attached to the video scope. So where you will have one channel where the camera is there, that is a dead channel where the camera is there. And once you put this video LMA, you can also intubate through this and see the endotracheal tube going through the vocal cords. Video LMA, there is one article, 2024 article, which says that this could be our present state and outlook for 2050, the video LMAs. The old combi tube is also still useful. So sorry if I took a long time. My take-home message, what I use for small procedures, iGel and Supreme. Rescue device, if I'm caught in a situation where I'm not able to oxygenate, I will use Supreme. Use whatever you use best every day. For laparoscopic short procedures, mind you, for long procedures, LMA has no role. Short procedures, I will use Proseal. LMA, if I had to decide whether I had to intubate through the LMA, I will use Proseal, iGel or Ambu or again. And at least one intubating LMA should be there with me, which is fast track. Thank you for your patient hearing.
Thank you, ma'am, for the exhaustive topic. I encourage all of you to please gather your questions and keep them at hand, because I will come back to you after the next talk. We will move on to the next talk, and then we will get the insights from our esteemed chairpersons as well with regards to how they believe LMAs can be handled. For our next talk, I invite Dr. Shraddha Naik Bahulekar for her talk on preoperative airway assessment, parameters that make a difference.
Good evening, everyone. Am I audible?
Yes, ma'am, you are audible.
Yeah. At the onset, thank you, Rsacp, for this opportunity. Thank you, Naveen sir, Indrani ma'am, Shilpa ma'am, for considering me for this academic piece. And it is really, making me nervous to speak after you both, because I don't know. I hope I do some justice here. Um, can you allow me to share the screen, please? Yeah. Okay. Is it visible? Is
Yes,
it
ma'am.
visible? Yeah.
It is. It is. You can go on.
So I am going to get through a very important area of airway management, the pre-operative airway assessment. So like we say, prevention is better than cure. So let us see if we can actually do something to analyze the airway beforehand and, be ready for what is in store for us. So why is it essential to evaluate the airway thoroughly beforehand? Because then we can prevent situations like difficult intubations or failed ventilations if you are prepared beforehand and you have a airway strategy at hand. It will reduce thereby the anesthesia-related complications, because airway is one of the most challenging things that we will face as an anesthesiologist. If you have a thorough airway examination and idea of what is in store with us, it guides us the selection of airway management technique of whether we are going to do orotracheal, or like sir said, we have to do the restricted mouth opening and we are going with retromolar or submental or a fiber optic, or we need to keep tracheostomy or a cricothyroidotomy at hand. So it will guide us for the airway management techniques beforehand. And the analysis of flow stream suggests that difficult intubation is one of the leading cause of claims in the US. Whenever a patient comes to us in the preoperative area or for the first visit, when we are going to evaluate his area, there's a basic roadmap that we should follow: a thorough bedside objective examination. Obtaining history of a prior airway difficulty is also of very much importance. If the patient has undergone any procedure beforehand and if he has a history of any prior airway difficulties they are recorded. Then looking for pre-existing or required or congenital conditions which will hamper or complicate the airway management, and conducting an advanced examination like imaging techniques or endoscopy if there is a problematic airway. And also, it is better to evaluate the access to the cricothyroid membrane in case we should need to do it. So, what are the methods of airway assessment? Firstly, there are traditional methods like the Malampatti score, the thyromental distance, the sternomental distance, the upper lip bite test, the interincisor gap, the mouth opening, and the mandibular diffusion, etc. And then we have the newer emerging techniques like the airway imaging, focus, nasal endoscopy, 3D imaging models, and of course, we cannot deny the new bug, the AI in the airway assessment. So just a quick brush through the traditional tests that we have been doing since our PG days. The Malampatti score, whatever are the airway advances, we do perform this test in each and every patient in that sees us in the anesthesia OPD. So we have 4 grades: class 1, class 2, class 3, class 4, which is basically based on the visibility of your soft palate, uvula, fauces, and fillers. And accordingly, class 1, 2, 3, and 4 are given. And class 1 and 2, or anything beyond class 2, is marked as difficult intubation. And the way to perform this is the patient is sitting with the mouth open, tongue maximally protruded, and the patient not vocalizing. Then we have the thyromental distance. So anything more than 6.5 we consider as normal, and anything less than 6 centimeters we label it as difficult laryngoscopy or intubation. Then comes the sternomental distance, the normal distance between the upper border of the manubrium to the tip of the mandible, and the normal values are more than 13.5, and if it is less than 12.5, it points towards a probably difficult intubation. The upper lip bite test. So we have the vermilion border, and we ask the patient to bite the upper lip with his lower teeth in the lower jaw. So if the teeth could protrude up to beyond the vermilion border, it is class 1. If it is reaches not up to the vermilion border but up to the upper lip, it is class 2. And if it cannot bite the upper lip, it is class 3. And 2 and 3, almost so 3 points towards a difficult intubation. Then we know the interincisor gap, which is normally 3 fingers to 4 fingers in normal patients. Less than 3 centimeters is a pointer towards difficult laryngoscopy. If it is less than 2 centimeters, then your LMA or the LCD insertion is going to be difficult. And also it is affected to an extent by the PM joint and the cervical spine stability. And also many other factors like pain or anything if the patients have lesions in them. So how are these tests useful to us, and how much is the predictive value? So there are a lot of tests that were done to see which of these tests is best, or it's turning out to be more predictive of an area, or which is more reliable. So this one was done in about 300 patients. The thyromental distance had the highest sensitivity. By sensitivity, we mean that the number of patients who actually had difficult intubations. So it had the highest sensitivity, negative predictive value, and accuracy. And then the upper lip test by test had the highest specificity, which means that a negative upper lip ULBT will have more chances that the patient is actually not having a difficult intubation. Then the Lemon airway assessment test had the lowest specificity and positive predictive value and accuracy. And thyromental test had the highest accuracy, followed by the modified Malampatti test. Interincisor gap had low sensitivity and positive predictive value, and Atlanto-occipital extension test had low sensitivity. So what we see is there is a variation, and there is a, what we can say is there are pros and cons of each and every test. Some tests have better sensitivity while others have a better specificity. So every test has a different profile. So what they concluded is that the current available screening tests for difficult intubation have poor to moderate discriminative power when used alone, and no single airway test can provide high index of sensitivity and specificity for the prediction of difficult airways. So the author suggested that we should combine various tests to come up to a better conclusion whether we are going to deal with a potential difficult airway. This was an article in IJA, which was a study comparing different airway assessment tests in predicting difficult laryngoscopy in geriatric patients. It was a prospective observational study conducted on 140 patients scheduled for general anesthesia elective procedures with age above 65 years of age. And where they showed that the thyromental response exhibited again the highest sensitivity and the negative predictive value. The positive predictive value of the upper lip bite test was 100%. Also, it exhibited the highest accuracy and high specificity for predicting difficult laryngoscopy in pediatric patients. So here what they concluded is that thyromental distance and upper lip bite test both showed good predictive value in diagnosing difficult laryngoscopy in geriatric patients, and also the thyromental height ratio. That means the ratio of the thyromental distance to the patient's height also exhibited higher diagnostic accuracy in predicting difficult airway in these set of patients. Now, this was a Cochrane's review of airway physical examination test for detection of difficult airway management in apparently normal adult patients. So, this study included 133 studies involving more than 8 lakh participants. And what they found was Mallampati test, Wilson score, thyromental distance, sternomental distance. And they studied all these tests together. And what they found is that for a difficult laryngoscopy, the average sensitivity ranged from 22% to 63%, the lowest being the mouth opening and the highest being the upper lip bite test, while the average specificity was from 80% to 95%. That was the highest was Wilson's score. And the upper lip bite test had the highest sensitivity of all the tests that they considered. Then for a difficult tube insertion, it took me a second here. So, sorry, I'm in the theater yet, so there's some disturbance. So the upper lip bite test had the highest sensitivity of all the tests that were considered. For a difficult tube insertion, the average sensitivity ranged from 24% for thyromental distance to 51% for modified Mallampati test. And average specificity ranged from 87% for the modified Mallampati test to 93% for mouth opening test. So the modified Mallampati test had the highest sensitivity of all the tests that they considered for difficult tube insertion. So what they concluded in the end is that the bedside screening tests examined were not well suited for the purpose of detecting unanticipated difficult airways, because they had missed a large number of people still who they felt that they could have had difficult airways. Now these are the Lemon scores and the Wilson scores. Since most of the studies showed that a single test, just a thyromental distance or a sternomental distance or a mouth opening, are as a solo test are not effective in predicting the difficulty, probable difficult airway effectively, which gave rise to most of the scores, which is the Lemon, which is the look, evaluate, Mallampati, obstruction, and neck mobility score. And they scored, there was a point on each of it for the external features, for the inter-incisor distance, thyromental distance, Mallampati score, any visible obstructions, and neck mobility. Similarly, Wilson score studied parameters like weight, head and neck movement, jaw movement, receding mandible, and prominent incisors, and they were rated, parameters were rated as 0, 1, 2. And the higher the score, the more the difficulty in intubation. So What are the limitations that we found of these tests? They had low predictive value when they were used alone. The upper lip bite test, a short higher mental distance, retrognathia, and a combination of findings based on Wilson score were found to be best predictors of a difficult tricky situation. Among the screening tests, the upper lip bite test seemed to be the most better predictor of difficulty in the airway. So these are the tests that we might just combine and use in patient for a more relatively accurate examination of the airway. And thyromental distance had the highest sensitivity and accuracy. Coming to the newer and emerging methods of airway evaluation, these are the methods that we have been doing for years. We still continue to do it, but with the emerging techniques, with the advent of better imaging techniques and ultrasonography, we have better tools at hand and with better accuracy for evaluating the airway. So there's something called preoperative endoscopic airway evaluation or nasal endoscopy. In this, what we primarily do is assess the upper airway and its fixture through a nasal endoscope, which can be useful for planning both tracheal intubation as well as extubation. The real time assessment of the airway, like airway narrowing, any distortion, presence of any pathologies or tumors or swellings or upper airway edema, can be directly seen through this endoscopic evaluation, and it can be performed in awake patients in sitting position in the preoperative workup area. So this is one emerging modality that is commonly done. So this is how the images look. This is how the normal glottic view will look from nasal endoscopy view, and this is how acute epiglottitis or edema might be seen through a nasal endoscopy view. So this view essentially give us a idea beforehand of what exactly are we going to deal in this particular patient's airway. What are the advantages? Like I told you, it will give you superior anatomical information about the patient preoperatively. Any pathology that precludes good mask ventilation or direct laryngoscopy or impedes successful tube placement would be easily detected beforehand, and so that our airway plan is easier to make. But it comes with limitations like it is an expensive and specialized equipment, which all centers or private practitioners or smaller centers or smaller cities and rural areas might not invest into. Also, you need to have a trained clinician who will be able to do this scopy in a patient in an appropriate clinical setting, because you can't just do it somewhere in a camp-like place where there is no backup available. Patient compliance becomes an important factor here, because passing the nasal endoscope through the in the awake patient is little discomforting to the patient, and therefore patient cooperation achievement is one task which can limit your procedure, and also it is time consuming. So hence it's not very popular or a go-to investigation yet in many of the centers. Then we have the airway imaging. So X-ray, CT, MRI, ultrasonography have changed the way how we perceive, change the way how we can evaluate airways preoperatively. X-ray imaging, of course, we can clearly visualize all the skeletal structure, the tracheal narrowing, deviation, all that. In CT and MRI also provide detailed information about factors that can lead to difficult airway, including the anatomical location of the tumors, involvement of the secondary structures, any distortion or narrowing of the airway at what vertebral levels, etc. Ultrasonography can visualize anatomical structures that are visualized by the video laryngoscope, as well as new ones which we cannot visualize through the video laryngoscope. And it is shown that the diagnostic index and the area of the curve of ultrasound were similar to those of CT and X-ray in predicting difficult airways. And moreover, ultrasound is very portable. It does not involve any radiation. It requires the lesser skill, fair amount of skills, but not which can be mastered by anesthesiologists. So it has become a very handy tool for predicting and all the airway structures. So this was an article in Journal of Clinical Anesthesia 2018, and they studied the diagnostic accuracy of radiological methods like X-ray, CT, and ultrasound for predicting difficult airway intubation in adults. And they studied around 17 studies with some close to 9,000 individuals, and the results indicated that the diagnostic value of CT, X-ray, and ultrasound were much better than the modified Mallampati score. And ultrasound had diagnostic indices and area under curve similar to those of X-ray and CT, like I told earlier. And considering this being easily and readily available, ultrasound can be considered as prior diagnostic strategy in this condition. This was a systematic review and meta-analysis for airway ultrasound as a predictor of difficult direct laryngoscopy, and they studied many factors, many tests like DSE, that is the distance from the skin to epiglottis, DSHB, that is distance from the skin to the hyoid bone, DSVC, which is distance of the skin to vocal cords, and then EVC is the distance of epiglottis to the midpoint of distance between the vocal cords, and likewise. And they studied all these index tests for the specificities and sensitivities. So the DSE, that is the distance from the skin to the epiglottis, has shown to have the maximum sensitivity like 0.082, and also a specificity of 0.79. Another important parameter that can be measured with an ultrasound is tongue thickness. So this was an article in British Journal of Anesthesia by Yao. Can tongue thickness be measured by ultrasonography, which will predict typical intubation for us? So adult patients undergoing tracheal intubation and general anesthesia were enrolled in the study, and tongue thickness was measured by submental ultrasonography in median sagittal plane like this before anesthesia, and 2,254 patients were analyzed. What they came to the conclusion and they saw in the results was that increased tongue thickness of more than 6.1 centimeters was an independent predictor of difficult. The primary outcome here in this case was difficult intubation. And they found out that the increased tongue thickness of more than 6.1 centimeters was an independent predictor for difficult tracheal intubation with a sensitivity of 0.75, specificity of 0.72, the confidence interval of 95%. Also, increased ratio of tongue thickness to thyromental distance presented a considerable area under curve. So these two things came out to be independent predictors of difficult airway, the tongue thickness and the tongue thickness to the thyromental distance ratio. Focus has a very good role to play in preoperative airway assessment in today's era because it is rapid, non-invasive, and a real-time assessment technique. The tongue thickness of 0.61 centimeter, like we just saw in this study, was shown to be an independent predictor of difficult intubation and can be very well seen to the ultrasound. Distance from the skin to the epiglottis is the most measured and studied test, and the distance of skin to epiglottis more than 2 to 2.5 centimeter is a predictor of difficult laryngoscopy. Also, we can do dynamic assessment of the vocal cords with the linear probe. Assessment of the subglottic diameter in the children can also be done, which is much superior to the conventional formulas that we use to estimate the tracheal tube size. Then, preoperative surface marking of cricothyroid membrane prior to anticipated difficult intubation can be done as a real-time procedural guidance. Also, this can be extended to doing gastric focus, where we can evaluate the amount, the volume of the gastric effusion's volume, and hence we can also thereby find out the chance of aspiration that the patient has. So this is if you place the transverse ultrasound image of vocal cords look like if you place the probe transversely, these are the vocal cords, and this is the anterior commission, and these are the arytenoids. And if you place the probe in a linear way, then what you see here is the thyroid cartilage and the cricothyroid membrane, and the cricothyroid membrane can thus be localized beforehand when you are dealing with a potential difficult intubation. We can also use this technique while performing a cricothyroidotomy under ultrasound guidance. Then there is something called as virtual endoscopy, which means a 3D airway model is constructed from the two-dimensional CT images. So we compile all these two-dimensional CT images to form a 3D airway model. A fly-through video is created by CT images, and the patient's airway is sort of reconstructed to give you an idea of how the airway anatomy of the patient will look like. Like we have the 3D, 4D images of fetal images in the obstetric ultrasound. In the same way, 3D fly-through videos can be created by CT images to create airway anatomy. This can help in better identification of a difficult airway to make an appropriate airway plan. So what they have found out, virtual endoscopy improves the diagnostic accuracy of airway pathology when compared to a single CT scan film alone. So this is how a 3D image is created from the slices of the CT that you have, and you have can travel through the okay. The advantages of this virtual endoscopy is that it's non-invasive, it's anatomically accurate, and a 3D fly-through view will give you a better idea of the airway anatomy than the single CT film alone. But again, it's expensive. The quality of the 3D video will depend upon the quality of the 3D images, and it is a static, not a dynamic real-time assessment, because it is just a 3D construction that is being made through your CT image. Coming to the tail end, we cannot deny that artificial intelligence is now everywhere, and it's a double-edged sword, which is good in a way if we collaborate with the existing systems, but it has a potential threat of replacing the actual skills that we have acquired through all these times. And yes, it is everywhere, and so is it in our field also. So AI in anesthesia aims to improve patient safety, optimize the resources, improve the quality of anesthesia management in all the patients. The AI tools are used to predict difficult intubation in perioperative settings, which will play a more crucial role than conventional approaches. The main AI methods used are machine learning, deep learning, and computer vision. They manually collect the characteristic features that might be associated with difficult airway, and then they train them into AI algorithms, which then will be used to identify the characteristic factors that will best predict the airway. A number of apps are also available which will predict difficult airway based on the AI technology. There are few robots which have come in, and mostly they are still being tested on mannequins. The Kepler intubation robot system, the Intubot, which is a real-time audiovisual based navigation system, portable robotic assistant intubation system like the RRAIS, and the Reality, which is the robotic endoscopic automated via laryngeal imaging for tracheal intubation, are quite just a few to name. This is how the Kepler intubation system looks like. So it has a joystick which will move through the patient's airway and find the correct way through the vocal cord, and the patient will be intubated. And this is the Reality system. Again, this also has the camera and a joystick, and with the button which you can remotely operate, it will find its way through the cords, and then the tube will be passed through. So the advantage is that they are really accurate. It requires less expertise for us to deal with a difficult airway. We need to have at least 200 odd intubations done to have a certain level of expertise in dealing with difficult airways. But with these systems in place, relatively novice and a newer person, junior people can also intubate accurately. So what are the potential advantages of the artificial intelligence in airway management? AI with USG or CT guided navigation in the real time can be used for airway anatomy assessment in endotracheal intubation. It has the potential to facilitate telemonitoring and real-time video conferences at remote locations. So it will help in a way where expertise is not available, and we are somebody stuck in a difficult airway situation where expertise is not at hand. But it has some potential dangers and limitations. First is the cost. Right now, at least, it is very high to be faced at every center. It can exacerbate bias if the data with which the AI systems are fed is inaccurate. The major issue here that we're facing right now is the ethical and the privacy issues, which have to be very meticulously dealt with. If AI has to be incorporated, the validation of the algorithm has to be done with a large data. And the most important thing I feel with AI is that it is a double-edged sword. We should make sure that it does not replace the skills and the clinical acumen of an anesthesiologist. It only helps it to make it more accurate. I wonder, with such beautiful, innovative instruments at hand, whether our PGs will really struggle to learn the technique of intubation. Only time will tell us. So the take-home message: the traditional assessment alone are insufficient. We should use a multimodal approach. Focus and advanced imaging may improve difficult airway prediction. Video laryngoscopy and AI are reshaping the way we have airway management, and it has a promising future. And no method of preoperative airway assessment is totally foolproof, including the AI. The clinical acumen of the anesthesiologist and preparedness for any unanticipated difficulty, in spite of all the best supply, is absolutely essential. These are my references. Thank you for the patient listening.
Thank you, Dr. Chadha. This was really exhaustive and completed the entire spectrum of what needed to be said. I'm going to now invite our chairpersons for a couple of questions that I have, and then we can open it up to the audience if they have any questions. My first question is to you, Jason sir. So, you heard Shilpa madam speak about the use of supraglottic airway devices in various surgeries, and what the private practitioners' outlook to use of supraglottic airway devices were. As somebody who practices to somebody who practices in an institute, do you subscribe to her views with regards to use of LMAs in laparoscopic surgeries? If you had to, how would you go about it?
So thank you very much, Gauri, for having me here and the organizers. And I'm really thrilled to listen to all the talks. They were really brilliantly covered by Dr. Shraddha, Dr. Naveen Malhotra, and Shilpa Madam. So yes, I am of the old school of thought. I do use supraglottic airway devices, but it's kind of a vicarious liability. I work at a training center where I have a lot of residents and a floating crowd. So I am happier to be inside the operating room continuously. If I'm out for a meeting or something like that, then makes it difficult. So the key points here is have a second generation supraglottic airway device for sure. We are done with first generation supraglottic devices because the oropharyngeal leak pressures and seal pressures that the second generation device offers is another level. Second, always whenever you're dealing with laparoscopic surgery, you have to decompress the stomach. I can't overemphasize that. I think Shilpa madam has spoken about it brilliantly. So you have to, for multiple reasons. One is you want to decompress the stomach to avoid the diaphragmatic splinting that she rightly mentioned. Second, you don't want an iatrogenic injury when they're introducing a trocar, right? So if you have an inflated stomach, you're going to cause more of viscous injury. So you have to have a nasogastric tube which is draining the stomach and which has to be open at all times. There is no point in having a nasogastric tube there and keeping it shut. The third thing is in case halfway through the procedure. So I would be a little worried about doing a steep head low with a robotic on supraglottic airway device. But if I have access to the airway, then in case I need to change the supraglottic device, I have to weigh the risks and benefits as to what my supraglottic device is going to offer me over an endotracheal tube. Okay, so in the hands of novices, any advanced indications of supraglottic airway devices like obese patients, like laparoscopic surgeries, like prone position, you have to be a little wary of things that you don't go overboard and be over enthusiastic when you are nearly entering practice. So definitely use a second generation device, you have a nasogastric tube and have the capacity to pull out and the right judgment to pull out the supraglottic device and don't hesitate to intubate or intubate through a supraglottic airway device if needed with a fiber optic scope and railroading an endotracheal tube. So these are the things that I feel are mandatory. So unless you do it on a routine basis in a normal patient, how are you going to deal with that kind of a situation in a complicated case? So that is why having your hands at multiple devices and training for these procedures is mandatory. As Dr. Naveen Malhotra sir said, that airway is the anesthesiologist's armamentarium, and there should be no looking back or no second thought about managing the airway. You should not be needing a surgeon's help to manage the airway, right? So you have to have your skill set intact with intubation, supraglottic airway device, emergency cricothyrotomy, rescue face mask ventilation, awake techniques, uh, fiber optic intubation, retrograde, all of those, retromolar, all of those that we discussed today, including
Thank
percutaneous tracheostomy and tracheostomy if the need be.
Absolutely. So thank you so much for your insight. I'll move on to Gauri ma'am now. Ma'am, with regards to the second talk, with regards to Shilpa Madam's talk, actually, when you have patients with a slightly difficult airway who are maybe at a higher risk of aspiration because they're obese or they're pregnant and they're undergoing surgeries, do you have a special choice with regards to what LMAs you would use? Or would you be okay with any second generation device?
Procil LMA will be better.
Hmm.
As far as giving protection against aspiration is concerned. And in fact, in a pregnant patient, I would not like to go for a supraglottic airway device. I would like to intubate the patient.
Right. All right. Thank you so much, ma'am. Umesh sir, I have a question for you. So, Shraddha ma'am gave this lovely talk about how it's important for us to predict a difficult airway. And, at Tata, we're always talking about that. You predict your airways first, you predict your airways first. But given the entire spectrum of airway evaluation technology also that is available or techniques, it's not possible to do everything for everybody. So, and sometimes your patient has to be taken on the table in a hurry. So if you had that quick 1 minute look at your patient, what are the parameters that you would want to choose? That 9 out of 10 times you're done and you know that this airway is safe for you to handle or unsafe for you to handle.
First of all, at the outset, I would like to thank the RSCP, President Sir, Patron Sir, all the organizers, Dr. Shilpa ma'am, for having me here over. We had a very nice webinar. All the three presentations were excellent. As far as this question is concerned, in the medical college, we all are getting always the emergency patients. In emergencies, we have lack of time always. So this question is very pertinent over there. Basically, mouth opening, which is the thing which we can immediately and fastly look for, and mouth opening gives us a very good idea about that. And as at the bedside, I always prefer upper lip bite test because that has a higher sensitivity. So if we don't have any much time and emergency patient has to be taken. And one more thing, in my old teaching, actually my teacher used to teach me that always you can see the size of grade 2. Actually, I don't know how true it is and how applicable it is. But if a grade 2 is larger size or it's adequate size, you will not have a difficult airway. Actually, he used to see that always. So this is one kind of thing which we can look for. If a grade 2 is of larger size, mouth opening and intubation will be easy. That was easy. But nowadays we have technology in that, and Dr. Shraddha already explained that we have USG in all OTs nowadays. So USG is a very boon in airway assessment. We are giving dissertations also related to that in airway. So these two things I want to highlight actually.
So a quick look at the mouth opening, an upper lip bite test, and a POCUS with the probe in your hand is what you would choose.
Also, what I would say is if a person has a bird-like face, a bird facies, you are sure to have a different intubation.
A typical anatomy.
With, retro, receding mandible and all that, and
Look at the patient carefully, it gives you a lot of clues. Whether he's short necked or no, if he seems to have any peculiar oral pathologies or tumors there, or what is the primary diagnosis. All that gives you the information right away within.
Yeah, neck and even the circumference of the neck.
Movement, the circumference of the neck.
Actually, Wilson score is there. There is a Wilson scoring system which we can immediately do.
Immediately
we can
apply
see any any
Yeah.
beard, patient is having large jaw, receding mandible, all these things we can give a quick review and quick look over there, and we can guess that it's a difficult airway.
So I suppose, I'm also somebody who practices only in an institute. So I suppose there's also something to be said about standardizing your technique of assessment of a difficult array. So what's difficult for you must be difficult to me and to everybody in that theater. So we are able to label it. So do you have a technique like that? Like, is there a common practice that all of you follow?
So what you follow at Tata Hospital? Like you have some only
I
for
Can I take that, Gauri?
Sure.
Yes, so I guess there is no replacement to all the different parameters. So single parameter, like Dr. Shraddha mentioned, is not likely to help you with airway assessment. So mouth opening, neck extension, sternohyoid distance, tongue protrusion, malam patti. So all of these, the 3-3-2 rule and 1-2-3-4-5 rule, or whichever rule that you. So it's a quick assessment. There are multiple L-Ganzuari's index and intubation difficulty score, and these are all some of the newer parameters that are available, which are nothing but a combination of multiple parameters of the single metric test that we are doing. So whichever you follow, make sure that it is standardized and it covers all the aspects, and don't ignore the new kids on the block with ultrasound and all of these other techniques. So if you're dealing with a patient population like maybe our setup, if you have a radiology PACS or ZFP or something like that, then you can definitely use all these softwares to predict or maybe replicate or do a three-dimensional imaging of the airway. And last but not the least, again, if you have a huge thyroid, if you have mediastinal masses, so the imaging modality is not only the responsibility of the surgeon. Whatever the imaging has been done, make sure you open it and see it for yourself as to where is the tracheal compression, what is the distal extent, will I be able to get past the distal extent, do I have a margin between the distal compression and the carina to splint the trachea beyond. So these are things. What is the patency of the nasotracheal? Is there a deviation in the septum? Is there a turbinate hypertrophy? All these things, even you can have a look and definitely size the endotracheal tube and look at all those images before you plan an airway. That is the important bit that I have from my end. Thanks.
Absolutely, sir. Thank you so much. So I suppose there's also when I was speaking with Shilpa madam before the webinar also with regards to how LMAs work and everything, there is uh, there is some safety net in actually being familiar with the equipment that you use also. Meaning, because second supra, if we look at all the evidence that is available, all second generation supraglottic airway devices seem to appear to be just as effective, just not as effective. Like you mentioned, all of the risk indices, even whether it is predicting a difficult airway or even addressing it with a supraglottic airway device, there are so many devices available and so many scores available to predict them. There's also what we need to be is familiar with whatever tool you're going to use, and you like madam said, use it in non-difficult airways to figure out if you're comfortable with it, and then maybe move on to the difficult airway. We have one question in the chat which
Dr.
I
Gauri,
just
sorry to interrupt you. Can we have Dr. Vishal sir's and Dr. Naveen sir's view on this?
sure.
Dr. Vishal sir is there. Dr. Vishal sir? I'm sorry, I think you can go forward.
Actually, he was traveling, so Swati is looking after the work of,
Okay.
in the absence of secretary, she is looking after the work of joint as a joint secretary. So Vishal is traveling, I know that, and we got teacher
Naveen
Dr.
sir,
Tej
you have
Kaul
to
also
say
there.
something.
Then I think sir is there, so when Dr. Tej Kaul is there, I usually keep quiet.
Dr. Tej
Thank
sir has
you.
to.
Dr. Naveen, to keep quiet is not a good thing. You have to speak something. You have to mention, you have to praise people, those who have worked.
Thank
You
you
will
very
not praise
much.
yourself.
I agree to you, sir.
But your
So
good things are being watched by others and they know what are the qualities of Naveen.
thank you very
All
much,
the three
respected sir.
speakers,
Thank you very much.
all the three speakers have been excellent, very informative, very lucid, and very pragmatic. I was highly impressed. I am sure all the listeners all those who attended this webinar have been benefited. We had a record gathering of the attendees today. It was more than our capacity. Ultimately, the organizers had to tell them to go to the YouTube. It speaks volumes of the people who have drafted it and great of the speakers that they made things very interesting. God bless all the speakers. Keep it up. Best wishes for the future. Thank you very much. Thank you, all the speakers.
Thank you, sir. Thank you for those kind words. And I echo your words. Uh, when Dr. Indrani Himant Kumar name is there, so she always guides everybody very nicely in the capacity of past national president of Rsacp. And
Definitely,
and
definitely.
and
I'm sorry I forgot her name. I'm sorry I missed it. But she is definitely on the top.
yeah,
Definitely.
and I am we have all listened very nicely, and we know that Dr. Shilpa, Dr. Shraddha, and Dr. Jason Doctor, Dr. Umesh, Dr. Gauri Aroda, they're all fantastic and fabulous faculty. But to be honest, sir, today I am highly impressed by Dr. Gauri Ganga Kirkar. The confidence which she moderated today's session, I'm very sure that she should be as a faculty in RSCP, and I'll definitely ensure that you are there as a faculty in the conference, and you are given a ample opportunity and platform to showcase your talent to the entire country. And we look forward, and you have really won our hearts with the confidence which you have moderated this session. You had three
Thank you so
heavyweights,
much. That's really good.
but you managed it very well. And
Thanks.
The job of the seniors should be to groom up the juniors, to train them to be the leaders of the future. They are the leaders of the future. They have to be trained. They have the capacity, they have the capability and the intelligence to lead the society.
yes, and I take this opportunity to formally invite you as a faculty in my capacity as president, RSCP, to the forthcoming annual national conference of Research Society of Anesthesiology Clinical Pharmacology to be held from 28th, 29th, and 30th March at AIMS, Batinda. Gauri, this is just now a formal invitation to you officially on record with no financial implications as of now. But definitely a faculty invite is there. And I extend this invitation to all the delegates. We have got excellent academic session lined up. Dr. Anju Grewal and her team are working day and night for the academic extravaganza on 28th and 29th. And then there is total Sunday is dedicated to hands-on workshops where we are going to have our esteemed faculty teaching and training the younger delegates. We got a TOT program on faculty development program for the simulation, which is being there on Friday and Saturday exclusively for 2 days. It's an opener, and we will be soon launching our editorial fellowships under the with Dr. Swati Chavda as the lead. Many things are lined up. So thank you, Team Maharashtra, for organizing this event, and see you all very shortly at AIMS Batinda, Punjab for the annual national conference of Research Society of Anesthesiology Clinical Pharmacology. Thank you very much.
Thank you so much. Thank you.
Can we take a last question, sir? Dr. Gauri, one last question is there in the chat box.
There's one question by Dr. Pramodini. She says there was she went for this case where there was an emergency exploratory laparotomy for an 83-year-old patient. They could see the larynx, the epiglottis, but they were unable to introduce the tip of the endotracheal tube through through what she calls a good morning larynx. The patient arrested after multiple attempts of an ETT insertion. They could not ventilate even through an LMA, and they were unable to palpate the tracheal rings when they attempted a tracheostomy. So they were hoping for some guidance with regards to what they could have done better, I suppose. Naveen sir, would you like to take that?
Sorry, this is to me.
Sure, sir.
I could soothe the larynx, epiglottis, but was not able to introduce the tip of the EDT through good morning larynx.
Bag
Patient,
mask ventilation was possible?
yeah, but
Yeah, I was going to say that.
but why patient arrested? That's a million.
A boozy could have helped if the larynx was visible.
No, was bag mask ventilation possible?
Because in the presence of bag mask ventilation, patient could not arrest, to be honest. And but we can ask Dr. Pramodini to unmute herself and to directly interact with us. We will be happy to do that. If you are there, madam.
Yeah, I'm there. Good evening, everybody.
Good evening, madam. Please.
Let me thank you all. It was a very good presentation by the entire presenters and good panel discussion. But I till today I did not get answer to uh, this type of patient. This patient came. He was elderly man, highly emaciated, and had abdominal distension, and was diagnosed to have perforative peritonitis by the surgeon, and was brought on the table for emergency laparotomy. So he was in hypotension, was on vasopressor also. So we tried intubation with ketamine and scoline. The Selix maneuver was done. I did not ventilate this patient with bag and mask. As soon as the ventilation, I mean his breathing stopped, I tried the first attempt of laryngoscopy and intubation. Larynx was easily visible, but the ET tube was not going. And so multiple times I tried to introduce, but it failed. So there was bradycardia. Then we gave atropine. The heart rate came up, and also a dose of adrenaline was kept ready. And again, after 100% oxygenation, not by ventilation, just with the emergency oxygen, we again tried to intubate, but it was absolutely not going. Tube was not going. So I told a surgeon who was standing near me, told him to take an incision for the tracheostomy. And he said, I'm not able to palpate the tracheal rings. So I suspected that it may be tracheomalacia. So thought of opening with a laryngeal mass with a high pressure. But it was a fertile exercise. Patient died afterward. After second repeated, I mean second ROSC, he died third time arrest. So I just want to know in such cases, what to do. Is it tracheomalacia? And obviously patient of perforative peritonitis with vomiting, he might be in dehydration. And of course, he was on he was in hypotension and on vasopressor, but it was emergency. Like 2 to 3 days, patient was in the wards, and they said now we have nothing left but to explore. So what did I miss in this patient?
What about Booji? Did you try Booji?
I had written that on the chat. I don't know. I didn't get a reply.
Ventilating using.
Did you try the Booji?
Sorry, that time Buji was yes, that time Buji was not available, but Stilette was there, and with Stilette I did try, but it did not go. ET tube did not go.
Flexi tip. Y'all didn't have a flexi tip.
No, the glottis was visible, madam. That was not a problem. The problem was, I think, did you try
Glottis was
Jonathan?
visible, but in the adducted position. It was not opening.
That's a little unusual. Was
Was
the
the
patient
mandibular
was
space
In
adequate?
spite of the relaxant, it was adducted?
Yes,
So what?
yes. But epiglottis and the cords were seen.
Was the mandibular space adequate? Because you could see the cords, but you could not
If,
introduce the tube.
The tip of
Like,
the ET tube could
sir,
not
I
go
think
beyond
sir, it is
cords.
the problem of curvature
Or
of the
whether
tube. Stilette can help, I
sorry,
think. Stilette should have helped
no, it
in
did.
this case.
I had Stilette.
Pramodini,
I
those
had
were
Stilette.
the days. Now we have so many gadgets, and I don't think we will face this problem now. Because,
But
see, now
madam,
you
But
know,
madam, see, she
sugar
wants
medals. We
what
have,
Yeah,
I understood
we
from
have
her
a
is
bougie, we have,
and
fiber optic endoscope, and we have video laryngoscope, and we have so many gadgets now, you know.
Leucothyroidomy also could have been
And
tried.
we also have better LMAs. Those days, LMAs were also not that good, you know.
yeah,
So we have
I
very good
agree.
LMAs now. I don't think
Agree.
we will fail, with the present crop of armamentorium. I don't think we will fail.
So I
but what
wonder whether in this situation, as ma'am has told that the patient was extremely cachexic. And so there are two
Yeah.
possibilities. Might be
The-
it is a partial laryngospasm, and then there is an anteriorly shifted larynx, which the tube couldn't be negotiated because the emaciation might have shifted the larynx because the supportive soft tissue structure was not available in this patient. I wonder, I guess that.
Yeah,
Dr. Umesh, that
actually,
can be there. Doctor, madam,
yeah.
was any
Yes, I'm
postmortem?
listening.
Was any postmortem done? No.
No,
So
no
see,
postmortem.
83 years old, cachexic
Yeah.
patient. Maybe there would have been some. Maybe I'm not sure. We have encountered one patient where an
Or whether there was
underlying malignancy
some,
there of the
some growth.
growth. Yes,
Yeah,
I'm telling the
malignancy. Yeah,
malignancy
yeah.
of the which was affecting the passage of the tube. But still,
Yeah.
you could have what is surprising is that you were not able to ventilate because that patient, even if that growth was
Sorry?
there,
He
was
might have had
difficult.
stridor, sir, stridor.
No, they were not able to ventilate the patient. No.
No, he would have presented with stridor, I said.
Yes,
It
yes,
was
yes.
an
That is what I'm saying.
obstruction.
If there would have been
No,
obstruction, would have been compromising the airway.
actually,
Madam, see, we two or three patients in the recent past we have
yes,
seen
sir.
80 to 90 years of age, absolutely coming for some other surgery, able to ventilate but not able to intubate. And fiber optic done and immediately shown that okay, you're able to pass a very narrow small tube and there is a growth lying down. And
Mm-hmm.
but not able to ventilate in a patient who had no history of respiratory distress in the preoperative period. That sounds a bit unusual because, but you are telling that you were not able to ventilate even with LMA and you would have done all the maneuvers and surgeon not able to palpate the tracheal ring. So that is also slightly because it's just opening up the trachea. And um, so, but yes, you are right. We lost the patient and um,
so
Can we
mass
rotate 82 in such condition?
mass ventilation wasn't possible at all, madam.
they
Sorry?
never tried. Actually, she honestly told, but we must congratulate her that she was absolutely naked truth about that. Okay, that we didn't ventilate the patient. Okay, we all
Yeah.
know that we should do just one compression before giving scoline, but they are right that they didn't do that, and that's why they happened this thing that they were not able to ventilate even with the LMA in situ. But those are the things of the past. But what is surprising is that a patient who didn't have respiratory obstruction pre-operatively, didn't have any stridor, and we are not able to ventilate intraoperatively. Not able to put tube is fine. We could have done all the maneuvers, different types of LMA gadgets, that is a different thing, but not able to ventilate and not able to do a tracheostomy. That is to be looked into, to be honest. Doctor, any opinion from you? Dr. Jason, doctor?
Yeah, so I was just mentioning, sir, that I'd put it up on the chat that a bougie or a bougie with the froa, which has a stillet inside, or maybe a smaller sized endotracheal tube, probably you could have a, we don't know the earlier history, whether he was intubated in the ICU at
No,
83, any
excuse
subglottic stenosis, any of
me, sir. 5.5 uncuffed also tried. 5.5 uncuffed. It was not going.
that also not going. Okay.
No, uncuffed
Unusual. Unusual
tube
for not
5.5
having
because when
symptoms.
second time arrested, I tried 5.5 also, which was uncuffed.
Madam, whether it is trichomalacia or a laryngospasm, the endotracheal tubes goes in. So that means
Yeah, it can be. It can be.
there must be some physical obstruction to it.
Yes, sir. Yes,
What
sir.
would have
I
been
think since he had vomiting and vomiting and intestinal obstruction, severe dehydration, and it was taken as an emergency. I did not do IVC screening and all, but with ketamine and scoline, I induced and I was trying to intubate. So that probably I should have done IVC screening to check the adequate hydration. In that case, probably because when he was awake, he was not intubated. He was maintaining his airway. It is only after giving anesthesia and scoline that airway got stuck. Like his walls became adherent to each other, and I could not negotiate.
Right.
How much ketamine was there and how much choline?
So
How much ketamine and how much choline?
Shilpa, I cannot hear you.
How much ketamine and how much choline?
Madam, she's asking dose of
See,
ketamine
actually,
and
he was
choline.
on vasopressor, so I was giving very, very, very slowly. He barely required 50, less than 50. It was 40 milligram of ketamine, and scoline only 50 milligram was given.
I was asking whether
With that, he was flaccid. I mean, he was totally knocked off. And fentanyl was given. Fentanyl I gave 25 only. He had hypotension also on vasopressor.
Yeah, I
That
was
is
wondering whether
understood.
25 scoline was given and he came out of scoline and went in spasm.
No, he never started breathing again. There was no spontaneous breathing.
Whether jet ventilation was available and
They were
neck.
doing the maneuvers.
No.
Dr. Shilpa, she told that whatever emergency flush was there, they were trying to maintain with that.
Yeah,
But
yeah.
madam, see, this is a very unusual case. I think you should report it also because with the possible causes which can be looked into. But as such, IVC screening would help you to.
No, I want to know from your experience, is it that we should give more importance to hydration, even if it is emergency? I feel myself that being an anesthetist, you usually cannot postpone this case of emergency laparotomy. That 2 3 days kept in the ward on conservative management, and then brought on the table, and patient is tachypneic, gasping type, and you have to intubate, and surgeon is just waiting to open the abdomen to put the drains. So all these things you make you have to induce this patient with high risk. Means I think I made a mistake of whether I should have really tried to see the complete hydration level, and then should have given a signal to go ahead with the surgery.
Madam, I will be very honest
A
with you.
person who was breathing
Madam,
initially.
Madam, I will be very honest with
Yes.
you. Lack of hydration will not amount to unable to ventilate.
कहाँ पे आता है?
Well, getting my point, madam. If you are right, these patients are dehydrated, their reserve is low, they are on inotropes, IVC would have been totally collapsed. But why not able to ventilate?
That endotracheal tube not going doesn't fit into, obviously it was a witness thing, but that itself is in its own, it's a little confusing in the sense
That there are two different scenarios: airway management,
and
that
fluid
which includes not able to intubate, not able to ventilate. Second is totally different: inotropes and hydration, right? So don't feel guilty about that. These patients are already dehydrated, sorry. So, but we have to find out why we were not able to ventilate. And I can say with my experience, there may be some underlying malignancy or growth which we have, which the surgeons would have missed it.
No, in an emaciated patient, why tracheostomy was not possible? I didn't understand that.
That is my point as well.
That is
At
also
least
beyond comprehension.
cricothyrotomy could have
What
been
about
tried, I think.
cricothyrotomy or something? Did you try a needle
Yeah,
crico?
jet ventilation,
Like surgeon was
cricothyrotomy,
not able to do
anything.
No,
What
no.
tracheostomy,
happened to
madam.
trachea? Why are these tracheal rings actually? Surgeon was not able to find the
No,
trachea. This is a
surgeon said,
mystery.
Done the crico,
surgeon said,
needle crico.
I cannot.
Those days we used to do only needle cricothyrotomy.
Okay.
But the surgeon was there. He could have done tracheostomy, emergency tracheostomy.
I agree to that. Surgeon, what stopped him in opening up the trachea? Patient is
Trachea,
going
मतलब it
otherwise.
was a
No,
dire
surgeon did
emergency. He
try
could
for
have opened the
emergency.
trachea.
Sir, one more
Yes, he
thing.
opened.
One more thing.
He
What
opened,
I have seen, when there is
but
a
he could not localize the tracheal rings.
when there
He
is
could
such
not
a critical
differentiate between the
situation,
tissue and the
surgeons are not able to do tracheostomy so fast.
The
They
That's
should have
ENT people,
located
they
the
are able
You're
to
trachea.
right.
actually.
Even if they could have taken a time, well, 3 minutes, 4 minutes, 5 minutes, it was enough to go through the trachea and give some oxygen to the patient.
Needle crico.
Needle crico, yes.
But
Cricothyrotomy is the technique of choice in hypoxic
that
patients.
is for we
Yes.
people. But if we are not able to locate the trachea or cricothyroid membrane, then surgeon was there. He could have started with the tracheostomy or any cricothyrotomy, whatever was the possible time at that time.
They were not
Now,
able to
what
catch
happened?
it.
He was not
What
able to.
happened to tracheal rings? Where they
No,
went? These
yeah,
actually.
cricothyrotomy was not done. But I thought the surgeon thought that he was a confident of tracheostomy, so he directly went on trachea and he tried to do the tracheostomy. But then when he took the incision and trying to put a snare around the tracheal ring, he said, I cannot palpate any tracheal ring. That was a thing.
That
By
means
that,
the trachea has been, deviated somewhere. That's why he's not finding the tracheal ring.
Because of
maybe
emaciation or because of some
There is
other
deviation
problem.
of the trachea.
So then the another thing which is coming up in the chat box, maybe some thyroid mass debating it, but that would have been it's so huge, so it would have been visible externally also.
visible.
Visible
Yeah,
It was only
no, there was
visible. So
no
no such
thyroid
swelling,
enlargement.
no such swelling. So quite an unusual case, madam, case that we are not able to ventilate. Surgeon is not able to do tracheostomy. So something abnormal is definitely there. In this old age group, it usually is a undetected mass.
So,
Okay.
Pramodini, my suspicion is that his trachea was, deviated from the normal. Maybe, sudden angle, acute angulation of the trachea or whatever. That's the reason when you go in the normal, where you find the cricothyroid, he
No,
couldn't
but
get the ring,
intubation
right?
would have been possible, no, madam,
There
in
was
that.
no ring
Okay.
at all. That means the trachea is not there.
Would it be
No, but intubation should have been possible in that case, no, with
retrosternal thyroid?
Exactly. If it was there, if the trachea was there, it would have been easy. Probably it was not there. It was, deviated.
Yes. I know.
So I hope you were able to find some answers today, madam.
Because I remember, arguing for one of my teachers, who did a TM joint ankylosis. The one, I think, TM joint was released, and after that, they had to do an osteotomy to bring the jaw forward. So it was such a difficult intubation. These are difficult. We think that now the mouth is open and then, we can intubate now, but it wasn't so. And she was also a case of hypothyroidism, which was not under treatment, not under regular treatment. So, madam, she tried intubating the case. She couldn't intubate. And then she tried to ventilate. She couldn't ventilate. Then she put a cricothyroid needle and she was trying to, give jet ventilation through the cricothyroid needle. She put two needles, one through which, she could jet ventilate and the other through which, she allowed some expiration. And then she asked the surgeon to do a tracheostomy. So So she had to remove the needle for the tracheostomy. So then, as the surgeon took 40 minutes for tracheostomy, and by that time she was brain dead because multiple times they tried to ventilate, atropine, adrenaline, the works. I mean, that went on, and finally, tracheostomy was done after 40 minutes, and the patient was brain dead. So this patient went to the court, and then madam requested me to, to take it forward in the local, court. So that's how I knew all the details about that case. So here was a case where she could not ventilate, she could not, intubate, and she tried cricothyrotomy. She was, of course, madam came out scathingly out, no problem at all, because she did everything possible, which is under the guidelines and which a person should be doing. So there was no problem. But then here was a case where a surgeon was needed to do a tracheostomy, and he took 40 minutes, and in a patient in whom we could neither intubate nor ventilate. And on top of it, hypothyroidism. So she is like,
Got it.
all this
Thank
was
you
a problem,
Thank you so much for your insights, ma'am. As I said in the beginning, that it is such a pertinent topic for anesthetists that you bring a airway situation or a topic, and anesthesiologists can tirelessly, discuss their experiences, expertise, and it is such a beautiful thing that being the experts in this field, we still have so much to talk about, to learn, and to teach, of course. And I must say, all the topics were suitable for everyone, right from the basics to the latest in focus in assessing the airway, all about LMA. So these were the excellent presentations today. And of course, Dr. Naveen Malhotra's presentation was icing on the cake. And I must congratulate Team RSCP from Maharashtra State to bring up this important topic. And with permission from the president, I would like to close today's webinar, and we would meet next in the webinar and in the conference as well.
Thank you, everyone. Thank you.
Thank you, and long live RSACP.
Yes, long live RSS.
Long live
Long live
RSCP.
RSCP, and good night to all of you.
Thank you.
Good night,
Long live
everyone.
RSSCP.